In the second section of our lecture, now we will discuss the screening and diagnosis. In this, we will discuss the physical examination of the patient with the prostate disorders, which can be prostate cancer or BPH or benign prostate hypertrophy. Also, we will discuss the prostate-specific antigen-based screening and the prostate biopsy. So the physical examination of the patient with the prostate disorder, usually the initial basic step for the examination is the digital rectal exam. That's the picture of the digital rectal exam, and then the finger with the glove on, usually when it's lubricated, and then just one single finger, index finger, is inserted in, and then it's used to feel if there is enlargement of the prostate gland or not. This is very first initial basic physical exam method, and that's called the digital rectal exam. DRE. Here on the digital exam, if you can see very straight, the prostate can be felt with the finger, and if it's enlarged, there is an idea if there is any tightness, rigidity, nodularity, that can also be felt by the finger. Then this is the symphysis pubis, prostate gland, penis, urethra, corpus cavernosum, corpus spongiosum, and the testis and the anus. So this is the physical rectal, digital rectal exam, manual exam. And it's based on the symptoms of the patient, abnormal digital rectal exam, and change or elevated level of prostate-specific antigen. So physical examination, again, the symptoms are very, very important. Patient usually comes to the office and tell the doctor that I have difficulty in initiating, there is dribbling of the urine, there is weak stream, all these symptoms are present, and then that's the first indication that tells the doctor that patient might have the prostate hypertrophy or some other abnormality. Or there might be, then we can go for the levels of prostate specific antigen in the serum. That's the other indication, if the levels are high, that we need to go for the follow-up biopsy and all the different tests. Digital rectal exam focuses on prostate size and abnormalities. So prostate size usually is, we can tell the size if it's enlarged or not, and any abnormalities in the texture of the prostate gland is also very easy to find, if it's nodular or if it's if there is bleeding also, if the finger comes, blood comes on the finger, that's also. So all these different things we can, different findings are easily detectable by the digital rectal exam. If you see here the normal prostate with the urethral opening, that's how the normal urine flow, straight line, if the prostate is normal with no compression of the urethra. Normal urine flow, and that's with the BPH tissue. When the prostate hypertrophy is present, you can see the flow is restricted because there is pressure on the urethra, narrowing of the urethra, and definitely naturally the flow of the urine is affected. That the carcinomas can be hard, nodular and irregular, so that can also be felt on the digital rectal exam if it's hard, nodular, irregular. induration, which is due to benign prostatic hypertrophy or presence of calculi or the stone. All these are different findings that can be present on the digital rectal exam. Then prostate-specific antigen. Prostate-specific antigen is produced by the prostate gland, and the increased level indicates the presence of the abnormality. This is the normal prostate-specific antigen that absorbs into the bloodstream. It can be in the free-form prostate-specific antigen, or it can be bound to ACT bound and alpha Mg bound prostate specific antigen. What is this prostate specific antigen? As the name shows, this is specific to prostate gland. So any changes in the level of prostate specific antigen tells us that there is abnormality or problem in the prostate gland. So prostate specific antigen is kallikrein related peptidase 3. KLK3. So kallikrein related peptidase 3 is a kallikrein related serine protease that causes liquefaction of seminal coagulum. So prostate-specific antigen is a kallikrein related serine protease. The function of this is cause liquefaction, smoothing, watering, liquefying of seminal coagulum. So that's very, very important function in the males this prostate-specific antigen has, which is produced from the prostate gland. It is produced by non-malignant and malignant epithelial cells. The serum level of prostate-specific antigen increases from prostatitis and benign prostate hypertrophy, and levels are not affected by the digital rectal exam. We cannot say that maybe the handling of the prostate or by the digital rectal exam the level might be elevated. No, the digital rectal exam has no effect on the level of prostate-specific antigen. It is produced by the non-malignant and malignant epithelial cells. It increases with prostatitis and BPH. Here if you see, that's the normal level, that's how much prostate-specific antigen is produced and goes into the bloodstream. But in case of cancer, it's very, very high level of prostate-specific antigen, and any high level of prostate-specific antigen is an indication that there might be a problem with prostate gland. It's inactive in blood. Complexed with protease inhibitor alpha-1 anti-chymotrypsin. So it combines or complexed with the protease inhibitor alpha-1 anti-chymotrypsin. And it is eliminated by free prostate-specific antigen is eliminated by the glomerulofiltration through the kidneys, and elimination of bound prostate-specific antigen, which is not free, is slow. Though the free is eliminated fast, but the elimination of bound prostate-specific antigen is slow. Immunohistochemical staining cause prostate cancer diagnosis. The prostate-specific antigen is mainly clinically organ-confined. So it's confined to the organ, prostate gland. Its increased level in the blood is associated with increased risk. especially if the level of prostate-specific antigen rises to above 2 nanogram per ml, the patient might die of the prostate cancer. So prostate-specific antigen levels are very, very important. More than 2 nanogram per ml is very, very poor prognostic factor and leads to death. The criteria is recommends diagnostic prostate biopsy. Some patients have no histologic evidence at biopsy of the cancer, but it's important that we find the high level of prostate specific antigen. We should go for the biopsy, but then other important feature is sometimes the biopsy, there is no abnormal histological feature present on biopsy or in the tissues. The goal is to increase test sensitivity for younger men likely to die of disease. The goal of the screening is the prevention of likelihood of death in young patients by early diagnosis. And then reduce frequency of detecting cancers of low malignant potential in elderly. So prostate specific antigen has higher test sensitivity in the younger individual, but it has reduced frequency in the elderly. Symptomatic prostatitis is usually the course of antibiotics for infection. For prostatitis, antibiotics are used before biopsy. Prostate biopsy is image-guided needle biopsy. This is the image-guided needle biopsy. Extended pattern 12-core biopsy. Sampling is obtained from the peripheral zone, surrounding zone. You can see the periphery sides of the prostate and lesion-directed palpable nodule. So if there is any palpable nodule present, lesion-directed palpable nodule is the site of getting sample. Visualization is by transrectal ultrasound, MRI. So the visualization is by the transrectal ultrasound and magnetic resonance imaging. Biopsy is from the periphery and from the lesion-directed palpable nodule. And the important thing is that even with the high prostate specific antigen, the biopsy, the histological findings on biopsy may not be indicative of any cancerous development. Abnormal prostate specific antigen and negative biopsy, repeat the biopsy after some time. So even if the prostate-specific antigens are the abnormal, biopsy is negative, which can be a possibility. So repeat the biopsy after some time. Biopsy pathology, presence of cancer examined, amount of cancer quantified based upon length of cancer within the core and percentage of core involved. So it's very important that pathological findings on biopsy depends on the how long is the cancer which is present in the core and how much percentage of the core is involved. Metastasis is rare. It's not very common. That's where the histological or pathological picture of the biopsy of the prostate gland. Direct extension of colon cancer and transitional cell tumors of bladder to prostate can also occur. So metastasis from the colon and the bladder can occur to the prostate gland. More than 95% of the prostate cancers are adenocarcinoma. It's a glandular tissue. Prostate is a gland, so it's adenocarcinomas. Rest are squamous cell tumors, transitional cell tumors, and the carcinosarcomas. Biopsy pathology is Gleason grading system in which dominant and secondary glandular histologic pattern are scored from 1, which is well differentiated, to 5 undifferentiated, and sum to give total score of 2 to 10 for each tumor. So this is the staging which is known as the Gleason grading system, in which dominant and secondary glandular histological pattern, the glandular pattern of the tissues present on the histology, they are scored from well differentiated to poorly differentiated, and that's very, very important factor for the prognosis of the cancer, as we discussed it so many times in previous lectures in which we talked about the cancers, that the differentiation of the cells is an important factor. If the cells on histology or pathological examination are well differentiated, the prognosis is good. If they are poor differentiated, the prognosis is bad. Measurement of histologic aggressiveness. Poorly differentiated area determines the biologic behavior. Recording absence or presence of perineural invasion and also extracapsular spread. Again, if the tumor is poorly differentiated, that gives the idea whether there is any perineural invasion of the neural tissue, or outside the capsule there is a spread of the cancer. So this is very, very important. One is the TNM grading, and then the other grading method here in the prostate cancer is the Gleason grading system, which is from the based on the appearance of the tissue under the microscope. That was all about section 2. Thank you for watching sqadia.com.